I'm really excited to introduce the first panel today on local and global challenges to health equity, moving from policy to action. And I hope that this will follow really well from Trevor's keynote this morning. We have a really amazing panel for you today. The panel is from that side to me. We start with our moderator, Alisha Wade. We have Dr. Lincoln Chen, Dr. Tracey Naledi, Dr. Tim Evans, and Dr. Ann Andermann. I'm going to allow each of them to introduce themselves, but just to give you a note about our moderator, Dr. Alisha Wade. So Alisha is a clinician scientist at the MRC Wits Rural Public Health and Health Transitions Research Unit at Wits University in the School of Public Health. She divides her time between clinical work and research. Her research mostly focuses on communicable disease and chronic diseases in developing countries, and her clinical work is as an endocrinologist at the Donald Gordon Hospital in Johannesburg. So without further ado, and because I'm conscious of time, I'm going to hand over to Alisha to introduce the panel today. Thank you very much.
Thank you very much, Jess, and thank you all for joining us this morning. We're really looking forward to a very free-flowing panel discussion, followed by what we hope will be a very robust question and answer session. So to begin, what we're going to do, or what I'm going to do, is ask each of the panelists to give us a little flavor of what they've done in this arena. I mean, all of our panelists come from very diverse backgrounds, and I think all of you have worked in multiple areas during your careers. So it would be very interesting for the audience to hear a few of your reflections on the challenges of how you move from development of policy to implementation of policy. And if I can start on my extreme right with Ann Andermann from McGill University in Canada.
Thank you very much. So for many years, I've had an interest in social determinants of health and how do we improve the health of populations. And what I have been doing for some time involves teaching first-year medical students their first month of medicine. And when they come into medical school and they're all bright and eager to save the world, but also very eager to get on with learning the basic science and so forth, but we stop them for 1 month and we hold them there and we say, you are just going to be one part of a very large picture in terms of what it takes to improve health and what will be your role in the healthcare system. And the Royal College of Physicians and Surgeons in Canada says that to be a good physician is more than just being a medical expert. It's about being a leader, a health advocate, a collaborator, a scholar. And so how do we teach them how they can play all these different roles? And also improving health, as we know, it requires more than just diagnosis and treatment. There's different levels of prevention, health promotion, action on the social determinants, and teaching them about this broader picture about how they can intervene to improve health. So this is, after 5 years now, we've had over 1,000 medical students go through this process, hopefully opening their minds to the broader aspects of how they can improve health, from basic science to clinical medicine through to public health and population approaches, and having that big picture overview. We also have work looking at the CLEAR toolkit, which tries to help in a very sort of contextualized way people from different countries or even within the same city identify how they can better support patients and also how they can become better community level advocates and national and global level advocates for improving supportive environments for health. So for instance, in our own local area, we've developed a community outreach clinic where each of the family medicine residents is assigned a community outreach patient, and we take patients and use patient navigators to help these patients enter the healthcare system and have comprehensive primary health care where otherwise they wouldn't be able to make that connection and that link. So we're trying to do these kinds of things. But I also, having worked in global health before and having worked with Dr. Evans here at the WHO, I often think about the global level issues, and there's a lot of problems and challenges, big problems like global poverty issues, child exploitation, the war industry, global warming and climate change, all of these things that require supranational responses. And one of the challenges I find is that it's a very crowded playing field in global health, but really we're still relying on having these national governments who have to work together to make these things happen. There is no sort of global government. And when I work in Indigenous health, one of the things I know that improves the health and creates healthy and safe communities is having strong governance, plus health planning, and using a continuum of approaches to improve health and engaging the people in that process. How do we take that and move it to a global level? How do we develop this sort of larger constituencies to be able to move forward these kinds of planning rather than just focusing on a single disease or a single bullet, because there are no magic bullets. We really need to have more comprehensive planning.
Thank you very much, Anne. Tim, can you give us a little bit about your perspective?
Yeah, well, mine started when I was here and I was having trouble with my academic program. And so I ended up doing a DPhil in agricultural economics because I'd had farming roots. And my topic was looking at the impact of parasitic blinding disease on subsistence farming in West Africa. It was onchocerciasis, or river blindness. And that study, which took me a little bit more than a decade, I was on the fast track in my DPhil, led me to understand that despite having similar levels of parasitemia or similar levels of decreased visual acuity, the impact in terms of agricultural production was very different, conditioned by a whole set of factors. And it got me very interested in the differential distribution of outcomes and risks in health, which I think is really what we're talking about when we talk about unfair distributions or inequities in health. And so from there, I had the opportunity to work with Lincoln Chen at Harvard and got more interested in the fundamentals of inequities in health. And Lincoln and I put together a book called Challenging Inequities in Health, From Ethics to Action, which I think was published in this century, but just. And then from there, I was working in philanthropy at the Rockefeller Foundation, where we changed the name of the Health Sciences Division to the Health Equity Division, because we felt fundamentally that the foundation's mission should be to promote more fundamental equity in health globally, and that was both between countries and within countries. And so I think those were some of the things that have sort of formed my career, starting from when I was in a similar position, I think, to a number of you here at Oxford, but rather just being driven by both the science and the imperative for us to really act on inequities in health.
Thank you, Tim. Tracey?
I am a medical doctor, and I specialized in public health medicine. And I am working for one of the provincial governments in South Africa, one of the 9 provinces, Western Cape. And about 10 years ago, we were challenged by the Premier Rasool at the time of the Western Cape as the health department to say healthcare is becoming unaffordable, and you as the health department are always coming with a begging bowl and trying to put pressure on Treasury and say, if you don't give us money, people are going to die. That is just not sustainable. Health and education are already taking more than 80% of the provincial government budget. And the way we are going, there will be nothing left for other areas of development. And then we started a project that was looking at evidence for upstream interventions that would impact on health outcomes. And that led us all on a whole journey within the Western Cape Department of Health, where we really started grappling with this notion of not really focusing on healthcare, which is an important issue, but understanding that that is only just but one element if we are talking about health in its broad sense, which is more than just the absence of disease. That if we really are looking at what our constitutional mandate is, our constitutional mandate is to keep people healthy and to live longer lives, and providing health services is only just but one part of that. So what are the things that we need to do? Who do we need to collaborate with? Who do we need to advocate to to address some of the social determinants of health. That then started, then we worked very much as an advocate with other departments to basically say, usually what would happen when we go to these interdepartmental meetings, the minute you start saying health, all other departments start opening their laptops and they do their emails and they think, that is not our problem. But over the last 10 years, I think we've really tried to shift the trajectory to make the other departments and other sectors to realize that just because we're talking about health, we're not necessarily just talking about health services. The other hat that I wear is that I'm the board chair of Decano Atlantic Fellows for Health Equity in South Africa, where what we are doing is we are developing young people, young activists, to actually develop programs that would advocate for health and social determinants. Because in our country, as you all know, we had apartheid, and in 1994, we had the new South Africa. And that transition from apartheid to the new South Africa was largely driven by civil action and civil society. And what happened after 94 is that a lot of those activists went into government. They became the public servants, and actually as South Africans, we became incredibly complacent, saying that, we've arrived, we've reached our freedom. And as now many of you may realize, we are backtracking on a lot of our gains, and that's because civil society has largely been weak. So there are many interventions in my country where we are trying to re-energize civil society and put power back to the people, and know that regardless of whether it's a democratic government or not, civil society still needs to be active, and civil society still needs to raise the issues. They still need to advocate for the issues. And so those are the two areas that I'm working on, but largely around health and understanding that health is beyond just the absence of disease, and that it takes more than just the health department to ensure that our population would be healthy and live long and healthy lives.
Thanks, Tracey. And then Lincoln.
I spent 14 years living and working in Bangladesh and India, and I've spent the last 12 years on China and Southeast Asia. 3 very quick questions and 3 very quick responses and points. How well is our global system in promoting health equity? How well are our local systems promoting health equity? And how well are we connecting the global and the local to produce health equity? These are big questions. Well, we have Dean Jameson and Larry Summer, who had a Global Health Commission that said there is a grand convergence of life expectancy between developing and developed countries. But that's a national average of life expectancy. It says nothing about we as individuals, as global citizens. And indeed, Sudhir Anand, who's a colleague of ours at Oxford here, has done the analysis of this on income, and he finds there's a grand convergence of national incomes. But the individual incomes, if you look at intranational inequities, has actually gotten worse on income. So what you define as equity makes a big difference. I think Professor Bell spoke to that. Nationally, how well we're doing? Well, we live in a very diverse world. Some countries in Asia have done very well. There have been Lancet series on China, Southeast Asia, India, and so forth. And all of them have gained, but we all know that people have been left behind. And statistically, those who are trapped by war do the worst. The bottom dozen countries are in war, okay? Then you have your poor and the marginalized, and of course we have the Rohingyas. But even statistics can be quite deceptive. Singapore has one of the longest life expectancies in the world. But did you know that 1.5 million of the migrant health workers coming into Singapore are not in the Singapore health statistic on Chris Murray's chart, okay? They're excluded. Okay, so you have no idea. In fact, wait, Richard Horton sent me an email saying, look at Singapore, Lincoln, what do you think? And I said, there's 1.5 million migrants that are not in those statistics, So you have that kind of issue, and of course, we know that the aging of the population is leaving a lot of disabled and homebound people behind in the healthcare systems that are not keeping up. this conference setting has been a top-down, how well are the global policies affecting the local? I think we missed how well are the bottoms moving up to the top, and also how well are we moving horizontally from rich to poor and poor to rich. I think that was the point about some of the Gates strategies. Now, I, from my Bangladesh experience, have seen the power of the bottom up and the horizontal coming from the poor environments. The BRAC, one of the largest NGOs in Bangladesh, had a conference on what they call frugal innovation. In other words, when you're poor, you have to innovate to survive. And so they held a conference of what it is that poor people do to innovate. And I myself in my career have observed this. Muhammad Yunus, who won the Nobel Peace Prize, he was a professor of economics at Chittagong University when poor farmers were trying to gain access to the grass in the campus. So he went to the administrator and said, could we let a few of these people lease the land in the campus? They said, yeah. So he went out there, he began to talk with the women farmers, okay? And he found out that they were all indebted to money lenders. So he said, well, you know, I've got some money, let me give it to you. And people said, well, the women will never pay you back. And of course he learned they all paid back. All the women paid back. And then he began the spreading of the microfinance revolution. I was at the beginning of the oral rehydration revolution that was transforming child mortality. That would have never happened if it had not been developed in Bangladesh. Because when I was at the Mass General Hospital, we had no need for oral rehydration. We had plenty of IVs, we had plenty of money, okay? We weren't in the villages without the bottles, okay? And so we needed to marry both the need of the Bangladeshi villages with the advanced sciences that were taking place on transport across the gut that was going on in Building B at Harvard Medical School. By the way, I might add, I just thought of it, that Tim Evans was the guy, a young postdoc that went to Bangladesh with BRAC, and he went to Abid, the founder of BRAC, and he said, you know, you're not reaching the poorest of the poor. He said, what? Your groups, your microfinance groups are excluding the poor. And Tim and Elena did a study showing that. But that led to BRAC developing what they call the ultra-poor program. I won't go into it, excepting the SDGs completely depend now on the ultra-poor program to eradicate poverty by 2030. So these are the kinds of things that happens when you go bottom up and when you go poor to rich. Let me close by saying, what is the future of health equity? I think it depends a lot on who and why equity is important. The who, unfortunately, we have Donald Trump, we even have Brexit here, and the people that vote for them, I don't think they would be at the top of the list for equity. And all of us are for equity, but that's not the way a lot of the politics is going. Why is health equity important? The standard reasons are it leads to, inequity leads to worsening efficiency of the healthcare system, imbalanced burdens of disease, emergencies and crises, lack of prevention. It also limits the potential of each individual. It generates tensions, even leading to violence. And finally, it affects the moral fabric of society. But health is not alone, as Tracey is saying. Health is linked to the other aspects of social justice. Okay, I think Sudhir Anand has actually argued in his paper with Amartya Sen that people tend to tolerate income inequality better than health inequality because people believe that hard work, enterprise, and talent should have some role in the distribution of benefits. But avoidable human suffering and pain is not something that people tolerate as easily. So I conclude by saying that it is the human empathy for suffering and the avoidance of pain that mobilizes people's empathy and also mobilizes public outrage, which is the HIV drug treatment story that has revolutionized HIV revolution, was the public outrage over the lack of access to drugs. That is the power of health equity.
Thanks, Lincoln. I want to pick up on some of the points that Lincoln raised, particularly with the idea of the directionality of policy making and health equity. So Tim, you're at the World Bank at the moment and involved in some global policy health making. Could you give us a flavor as to how the local context is taken into consideration when the World Bank and other global organizations decide on what they think health priorities should be?
Great, well, thanks. I think we work primarily with countries and governments in countries, and so our rhetoric is that we're client-led, clients being the countries. And so whatever we do usually has a very strong engagement with whatever the local policy of the day is in a given country. Having said that, there is something called supply-induced demand, and because we lend and we have boards, we have to have a strategy that's defensible. And in that regard, we in health have identified universal health coverage as our umbrella strategy, and what we've found is that this is something that virtually all clients, countries, politicians, but also citizens are very interested in. Our president often talks about the equality of aspirations globally, and this is this recognition that in today's information age, somebody living in a rural area of Ethiopia knows exactly what the best healthcare options are for chest pain and potential heart attack, because they're linked by SMS to their cousin who is either a taxi driver in Washington or may even be a resident at George Washington University in cardiovascular medicine. And that's an instantaneous link. And so that spread of aspiration, that hope and expectation that societies will deliver good quality healthcare to everyone is something that isn't a pie in the sky coming from us. This is when you talk to people in communities, they have every expectation that their lives are as important, that they will have access to the care that they need when they need it, and that their politicians need to be accountable. What we find, however, is rather sobering. And the first do no harm premise is violated in multiple ways. And most fundamentally, for a lending institution, the way in which healthcare systems are financed globally is absolutely immoral. We have the most ineffective and inequitable way of financing health globally, and there's not a shred of evidence that supports it. And it's pay as you go. When you're sick, you pay out of pocket. No theory or evidence suggests that that's the way to go forward, yet when we look at that globally, over 100 million people a year are pushed into poverty. So we're doing harm. Second, of the total child cohort born every year, the majority of them are not given any official identity. In this day and age, this information age in which we live, with the majority of children being born invisible. So when it comes to really knowing who's dying and where and why, we have to rely on very sophisticated models, which at a global level give us a bigger the general picture, but at the local level don't give us that timely, real-time information that we need to know what to do to address residual causes of child mortality or maternal mortality. So we're not counting individuals. And if you're not counted, you don't count. So that's the second area where we're really failing. And the third is we still have prehistoric attitudes to some very, very common illnesses, particularly mental illness. And that is dealt with primarily through the criminal, I was going to say justice, but I'm not sure it is a justice system. It's a criminal system. And so that's not only in low-income countries where people with psychotic breaks are either shot or put in prison or locked up in chains. It's also in Western states and societies where bedlam is famous in England, or in the United States, where the criminal justice system is dealing with an epidemic of substance abuse and mental illness, but the health system is just not sensitive and responding quickly. So these are things where we're trying to say you've got to pay more attention to first doing no harm and including everybody if we're going to be truly universal, and recognizing that their entitlements to health are ones that society has to organize around fundamentally.
So Anna, I see you nodding. And I know a lot of your work is directed towards training future healthcare professionals. What do you tell them about the world that they're going to go out into? And how do you equip them to do the best for their patients in a healthcare system that has such social constraints?
So I'm nodding because I think we do have some very good models about how we can improve health. The province of Quebec actually has a very progressive Public Health Act, and it also has a population health approach, notwithstanding our current minister and reforms, but we have a population health approach, which means that when we divide up our province into different regions, there is a responsibility for every person on that territory. And so they are counted. There's a certain number of statistics and measures of health which are used as part of health planning. There's a national health plan for the province and regional health plans and also local health plans. And all of these sort of go together to try to improve the health of the population and to reduce the gaps between those who have and those who have not. So I think that there are approaches like this which are very positive and engage people also at the local levels to be able to inform what kinds of changes are needed. And I think there's also a link that we can make, and something that we had worked on back at WHO, which is the World Health Report on Primary Health Care, a model that was actually started in Falela, South Africa back in the 1940s by some community health doctors who found that there was a revolving door of health issues that were coming back to them time and time again. And they were saying, well, what can we do about these issues? And rather than treating each disease as it came through the door, they started asking the community what were their needs. And the community would say that they have various needs. Maybe there's an issue of violence, maybe they need a safe place for children to play, and so forth. So whatever those needs would be, they tried to troubleshoot and create those supportive environments in the community, this community-oriented primary care approach. And I very much think that going local and moving things upward is very important. And when I work in the Indigenous context, I think what's very important is that engaging the local government, because they really, if we're going to do intersectoral action, if we're going to work with other sectors, the local government has to be there, has to be present, and has to be really engaged in wanting these changes to happen. Because if you want to do something about mental health, about drug abuse, about all of these different things, using an implant, against HIV is just one harm reduction strategy, but really you want to create these supportive environments from birth, supporting parents, having childcare options, education options, and so forth, opportunities for work, after school activities, elder care, caregiver support, all sorts of things across the life course. And these things can start to be developed at a local level, but eventually these things can also be developed more broadly as well. And I think using these small communities as models and working community by community in developing this would be something that is an approach that one can take forward.
So Tracey, Anne has just given us what I think is an ideal list in many respects of ways one can improve health and certainly, for example, support health in children. You're at the coalface of policymaking in South Africa, which is a middle-income country, which is resource-restrained. How do you deal with that kind of list? You've mentioned when you meet with your colleagues in your provincial government cabinets, they're, decide this is time to do their emails, et cetera. They don't really necessarily understand or appreciate that there's a necessity to incorporate or understand the impact of health in a multi-sectoral fashion. So one, when you get directives or initiatives coming down from global organizations, how do you manage that at a local level? But also, how do you interest your colleagues, and how do you manage to find the money to try to really implement the policies locally that you think are going to make a difference in people's lives?
So I think, firstly, to say my colleagues in the provincial government have really changed. So just in case they hear that I said they're doing their emails. So I think the trajectory has definitely changed in the Western Cape, where I think we all understand that we have a role to play. And working with other And I'm not even talking other sectors out of government yet, which is hard enough. Just working within a provincial government with different departments, Department of Education, Department of Health, Department of Housing, Department, is a challenge on its own. And it's a challenge because as a government, each of us are given our own budget and we have to account for that budget. And each of us are structured in a slightly different way. So for example, our boundaries are different. We might all, we all provide service to everybody, but our boundaries are different, so it becomes a bit of a challenge now if you are going to say, this is a population within this geography. How do we provide services, health services, education, and provide all their needs, looking at it from a social determinants perspective? And if you are working with other people who cross boundaries, then you have to speak with two different managers, you know? So at the coalface, it's the logistics like that. It's time. So you have to have multiple meetings to get things done. So everything happens incredibly slowly. It really moves at a snail pace. Then, I mean, Anne, you were talking about local government. In our country, even the budgeting cycles of provincial government are different to local government. So that is also a different, and their governance structure is different to provincial governance structures. So it's kind of those operational issues that you have to deal with. But I think we are trying to find a way of working, and what we've done is that we've actually allocated particular heads of department that might, so for example, in my province, my head of department is responsible for a particular area, which is Saldanha. When she goes there, she's not going there as the head of department for health. She's going there as a senior manager for the provincial government. She has a mandate from the provincial government, and she's speaking on behalf of provincial government. And she has a mandate from all her colleagues to say, you need to hear first what are the needs are and take it back and say, how can we work together to be able to support those needs. In terms of policies that are coming from outside, I want to use, for example, money that comes from, I won't even go outside of our country. I will take money that's coming from the national government. The way in which we receive money, we receive equitable share that goes into general services, but we have some kind of money called conditional grants, which is money that you can only use for specific purpose. In this instance, it's around HIV/AIDS. I mean, I was interested when I was listening to Tariro speak about the incident where there was a patient who was HIV positive, could have whatever it is that she needed, but next to that patient, there were other needs that were not seen to, because the money that you are receiving is very much verticalized. It is for HIV/AIDS. So what we've done in our province is to say, actually, thank you very much for the money. We will take it, hold us accountable for the outcomes that you want us. So if you want us to put X number of people on treatment, we will do that. But please don't micromanage us about how we're going to do that. So what we've done is that instead of creating posts for ART doctors, we've created medical officer posts. And so that doctor is going to see all patients. So what we've done is try and improve the health system as a whole, because we realize that this verticalization is actually not delivering on what is our key mandate, which is about improving health services and also improving the health of all people. So what we try and do when we do get vertical money, be it from donors or whatever, we negotiate hard to try and allow ourselves some space to be able to use that money to rather strengthen the health system. If it's money that is for labs, we'd rather strengthen the whole system rather than a lab system that is just for HIV/AIDS or et cetera. But it's a hard conversation to have, because I think donors are, you know, there's also a power issue. You know, so if a donor's coming with money, you know, they also have the, I suppose, the liberty to say, if you're not going to do things the way I'd like you to do, I'm going to pull out. But I must say, the donors that we've worked with, PEPFAR, Global Fund, have been open to the idea of us doing the money differently. So I guess what I'm saying is that as policymakers also, we need to also have agency and understand our own power and know that when people are coming with ideas from even, I mean, we also push back from the National Department of Health when they want us to do certain things, and we say, no, in our context, for our context, that's not gonna work. We agree with you, this is important and we need to do it, but give us a bit of space to do it in a different way. And I think, particularly I think in developing countries, that power where we feel that we can say, not like that, but like this. And I think there needs to be more of that voice and being held accountable for delivery of outcomes. Don't micromanage people and tell them how to do things when they actually understand their own context better than somebody from outside.
So Lincoln, I'm going to come to you in a minute because I want to get some more thoughts, some of your thoughts on the politics of healthcare. But Tim, I want to ask you as a donor, when you go to Tracey and say, okay, I want you to do project X, and I'm going to give you this amount of money. And Tracey comes back to you and says, thank you very much for the money, however, we're going to use it for this. What's your response to that?
Well, let's have a discussion. I think the dance is an important one, and it is a dance, and in part because often people are in Tracey's situation who are part of governments that we're making loans to, aren't working always in the best conditions, meaning they're strapped, they don't have, we do a lot of work on health financing, and they may have one person in their Department of Health who's responsible for financing. And so making sure that they've got evidence on the state of financing of their health system and things like that are important parts of getting the conversation going in such a way that one can generate projects that are contextually relevant, but which we can get approved at the level of our board as being likely to generate results that, that our institution stands behind with respect to universal health coverage. So I think that this is part of it, but it's not a dyadic relationship. It's not just us as donor to representative for government. I think the reality of health systems everywhere is they're incredibly pluralistic. And so if you miss out on civil society, on big NGOs, on the private sector, you're missing a huge part of the health system. And so one has to think about, well, what constitutes the system that you're working with? If the private sector in the healthcare system that you're working with is either much bigger or the vast majority of resources are serving a minority of the population, then to exclude that from the stewardship of the overall system is a big mistake. And so some of these issues, which are real issues in contexts that I think you're familiar with, but in many other places, you've got to start to think about that stewardship in a much more collective way. I think also, though, and this is where, the bottom-up also requires a top-down, and it's not top-down from donor, it's political will. So, we might never have done PEPFAR had the advice of the lead USAID administrator at the time be followed, who said, no, we shouldn't do antiretroviral therapy in Africa because Africans don't know how to tell time. They don't have wristwatch. Right? This was testimony in front of Congress in 2001 on what a bad idea it would be to take on antiretroviral therapy. Prevent HIV, sure, but not go treatment. So this was something that the public health establishment, quite frankly, said wasn't cost effective. And I think this reality of putting the value of people's lives first in taking action is often one that trumps the best expert opinion. And therefore, the top-down action, which was to actually move ahead, President Bush came out with the $15 billion 5-year PEPFAR program, was not listening to the experts. He made a very strong political decision that it was time to address this massive inequity globally. And that's tough action, but we run into it every day. When I was in Bangladesh, we were trying to start a community midwifery program. And we couldn't get accredited because we were going to produce community midwives to standard in 18 months. And the accreditation authority said, no way, it takes 3 years. And we said, well, if we can prove at the end of 18 months that these midwives have all the skills that people trained over 3 years, why would you argue with a 50% efficiency gain? And they said, it doesn't matter, we have to have 3 years of training. So that sclerosis that comes into the professions, of which many of you will be part, if you're not already, is something that we really have to be wary of. And it picks up, I think, John, on your point. The pillars and temples of knowledge and the way that we've created them often end up being insufficiently flexible and responsive to real-time need. And so I think one of our challenges is how do we address structural skews in the way that we generate knowledge and that we apply knowledge? Because when you look at this from a knowledge perspective, it's perhaps the most fascinating area of knowledge on Earth. How do we achieve global health equity, right? But if really addressing it requires then moving us beyond and addressing some of these structural skews so that when we look forward, as we were told earlier, asked earlier with respect to the 2055 vision of some of you retiring, if I'm still alive, I'll be delighted. But what is that distribution and that system for knowledge generation in which countries are in a much better position to generate their priorities and manage those enterprises than they are currently? And that leads you to some real questions as to, and this gets back to our thing, why isn't there more investment in R&D and in delivery science in low-income countries? Because with fewer resources, the premium on using those resources to maximum impact to address inequities gets even higher. So the knowledge to make those connections has an even greater return on investment. Yet, we have a lot of difficulty getting R&D departments, medical research councils, or even tertiary level education institutions with the requisite manpower, sustainability of the knowledge side of this, which is really one part of where the innovation will come from. So I think my point would be is as we move together and try and come up with projects that we think are best, we always have to remind ourselves, are we addressing some of those structural anchors that are really keeping us from moving forward as quickly as we might? And how can we put those out on the table as being more negotiable such that we can open up really exciting opportunities to go further faster?
Thank you very much, Tim. So Lincoln, I'm going to throw a question to you, and I'm going to apologize in advance, because I want to ask you a little bit about the international politics of healthcare. And we don't have very much time left. But I think Trevor opened the door a little bit earlier, so I think it's reasonable for us to walk through it. A lot of the financing for healthcare in lower and middle income countries comes from high income countries, particularly I think the US. And obviously there are domestic political situations, as well as broader foreign policy goals that influence how that money is spent. How do lower middle income countries manage that? And how can higher income countries take a different perspective, possibly as Tim alluded to with PEPFAR, for example? How can they take a different perspective to make sure that the money gets to where it really needs to go?
I'd like to be the first one to tell everyone that we're at a tipping point in the global health architecture. The 19th Party Congress just completed We just had a workshop in Beijing University. The world is changing. The first Global Health Conference was in Paris, 1851, that led to the creation of WHO. I think the next big event in global health was the entry of the Gates Foundation. But I think today, the tipping point has been reached where China and the Asian century, the 21st century, is emerging very muscularly and very, very publicly. So I've been spending the last 9 months trying to get a paper published in The Lancet, which has finally been accepted, describing what's happening in China, because everybody in the West, nobody knows about these things. What's happening? It's probably the wealthiest country in the world right now. It's certainly the largest trading nation in the world. It's got the Silk and Road Belt Initiative, which is 12 times the size in absolute dollars as the US Marshall Plan. These are huge, huge. It has the Asian Infrastructure Investment Bank, along with its sister funds, that's larger than the World Bank capitalization. And the Chinese are very muscular, and they see the world in a very Sino-centric form. I actually don't like what they see, but they see a middle kingdom. They see China back to its emperor status and the walls around this country with all the tributary groups around. And the British and the Americans, these were all aberrations of the last 2 centuries. Okay, so I'm saying all of this because this is what's being unleashed in the next several decades. And I think we should be prepared for it because the R&D money is being hugely invested in China. Gates Foundation is supporting a lot of that, but the Chinese is 100-fold what the Gates is putting in. They don't have a very strong equity dimension. They have a lot of health security concerns because they're a trading company. They go all the way back to the quarantine and the Italian tradition that we don't want disease coming into the country or spread. So they sent 1,200 people to the Ebola. They're not building healthcare systems. They have a huge investment in South Africa. So I'll just close by saying we are at a tipping point in global health, and I'm predicting that this field will look entirely different in 10 years from the way it looked 10 years ago.
Thank you very much. So now I'd like to open the floor to questions from the audience. Lots of questions. So we're going to take them in rounds of 3. If when you are posing your question, if you could just tell us briefly who you are and where you're from. So we'll take the first 3 questions directed to the panel, and then we'll take the next round of 3. We have our roving mics.
Can I go first?
Cheryl? Yeah, please.
So I'm an academic in a
Thank you.
So my name is Vishwajit Namgaonkar. I'm an academic in a middle-level university in the United States. And it's very inspiring, actually, to come to this meeting to see the leaders in the field being so idealistic. I've been involved in sort of trying to do similar things in a smaller way, in a more idiosyncratic way in developing countries. And I see there are 3 big elephants, and I'd like to see how you deal with them. The 3 big elephants are the A's, B, and C's. So A is apathy, B is bureaucracy, and C is corruption. And those things permeate all that you'd like to do at the top levels in terms of implementation. So I'd like to know from the panel or from the audience, what can be done in a practical way for these issues?
Okay, thank you. Next question with microphones. Thanks.
Can you hear me?
Yes.
My name is Catherine Chu, and one of the hats I wear is I'm on the board of MSF Southern Africa. So just a comment, and then I'll pose my question. So Dr. Chen, I really, really appreciated your comment about, local solutions, or asking sort of the recipients of all the funding and the policies kind of what they think is important and what their solutions are. So I was involved with MSF in something called the community adherence groups. So antiretrovirals, when they first introduced in Southern Africa, was a tertiary hospital treatment. Infectious disease doctors, pediatric infectious disease doctors had to dole out the antiretrovirals. And soon it became clear that this was becoming an access problem. So at some point, this was decentralized all the way down to the district hospitals. But for a lot of our patients in Southern Africa, even that is very difficult. To come every month to a district hospital to pick up your medication still was prohibitive. And so we asked the people, the patients, and they said, well, why can't we form our own groups? And we'll get together in groups of 6 or 10, and we'll talk among us, and if everybody's healthy, then one of us will go to the clinic and pick up the medication on behalf of everyone else. And so this is a local solution, I think, that has really become a paradigm shift in antiretroviral distribution. And so what these adherence groups, these CAGs have done is also, I think, demedicalized health solutions in healthcare. Because to be honest, we're talking about health equity, most of the world is always going to have difficulty accessing a physician. And I'm a physician, so I will say that there always hopefully will be a role for us. But for most people, living, for example, with HIV is going to be a lifetime. Living with diabetes is going to be a lifetime problem. So with these community groups, they are now part of a peer group that discusses the health consequences of living with HIV. And so the ART delivery is only one small part of this. And so, why not use patients as advocates for health? And so I just wanted to pose to the panel, what you think other solutions of demedicalizing healthcare can be. Thank you.
Thank you. And a third question, perhaps one from a scholar, a current scholar?
Okay. Hello. Hi, I'm Arijit. I'm a second-year Rhodes scholar here. So my question is particularly in the light of what Dr. Lincoln Chen just said about China having both the capital and the political will for investment in healthcare in this century. You also talked about the Sinocentric view of the world together with that in the same discussion. So my question is how does the Sinocentric view, which sort of puts it at odds with several other Asian players, India being a prime example of that, how is that gonna influence the Chinese ability or the willingness to invest in healthcare for a better Asia or for a better world, despite all the political will that it has?
Wonderful, thanks. So why don't we start with that first question, apathy, bureaucracy, and corruption. Tim, can I throw that one to you for your initial comment?
Well,
Yes.
You okay?
There's none of that at the World Bank, I can tell you. I think it is a great question. I think one of the challenges of any big bureaucracy is how you create a constant sense of renewal. And the bank, as a big bureaucracy, I think, runs into the same challenges of any large bureaucracy, which is sometimes the rules become the end, as opposed to the platform that you're working on being the opportunity to foster and develop creative solutions to the pressing problems that you're there to serve. I think one of the things to recognize in big bureaucracies is that despite the rules, they're always incredibly malleable. And so when Al Gore did his big review of the US bureaucracy, he didn't come away with the ABC. He came away impressed by how much is being done despite ABC. And so I think that's something to keep in mind, is that you can't simply throw the baby out with the bathwater and start anew. You really need to recognize that there is some intelligence in bureaucracies and some opportunity to have them work better. But let me give a couple of specifics on the issue, on one issue in particular, and how there are opportunities related to different things that we run into. So in the Ebola response in 2014 in Sierra Leone, we were supporting the response, and this led to a mobilization of crisis workers. And crisis workers got top-ups, crisis salaries. And what we observed is that the role of healthcare workers and crisis workers was growing exponentially. It got up to 22,000 workers. And what we then did is we said, okay, well, why don't we, instead of having payment done by brown paper bags being carried to the front lines that were full of cash, why don't we move it to an electronic system? And so we said every health worker must have a bank account, and we instituted in a matter of weeks an electronic transfer payment of accounts. And that simple mechanism led to a cutting of over 50% of the number of workers needing pay. So it took care of what is a chronic problem in bureaucracies in many countries, which is the ghost worker problem. And so that's a massive gain in efficiency. Another example, medical equipment procurement. We do a lot of that at the bank. They call that hard investment. But when you look at how it's done, it's very vulnerable to all sorts of vested interests along the entire sort of value chain, from granting a contract to a bidder to delivery on the front line. And so one of the things that we've been working on is to change the system of procurement from capital expenditure on a facility-by-facility basis to a system-wide procurement based on tenders for a lease of certain lots of equipment. And what we've found when we've moved that, something called a managed equipment scheme, is we've taken the time for delivery of that equipment in real settings from 2.5 years to 6 months. And those that are providing the equipment, they don't get paid unless the equipment in place is in good functioning order. And so overnight, or in 6 months, this country has eliminated this symptom of equipment graveyards. When you go into a healthcare facility and the laboratory equipment is broken, and the centrifuge doesn't work, and the ultrasound machine is broken, they've transformed that in such a way now that at district hospitals in this country, patients are coming in at rates because they actually see that there's a good service. It's credible. And they're having now the opposite problem of handling too many patients because the services have improved. That was a simple way of eliminating a massive amount of bureaucracy and corruption, and with great value delivered to the patient. So what I'm saying is that when you look at how to address discrete parts of the system in terms of where there may be unacceptable inefficiencies, there are just a multitude of opportunities providing we're prepared to actually take the risk and move forward with doing business differently.
And the medicalization of healthcare?
Well, one thing I wanted to come back on, is again the big picture with my public health hat. I always like to sort of zoom back out again, because the question about what can we do to change, the situation in terms of global health, I think really comes back to Dr. Chen's comments about, global politics, and do nation states really want global health equity? Or do they have other agendas? And clearly they have some very specific agendas that they're trying to pursue, and other countries have their own agendas. The US has its agenda, all different countries have their agenda. And is their agenda really about global health equity? And in my work with Indigenous peoples, and working on this, violence epidemic that we see, where UNICEF says that 1 billion children have experienced violence in the past year, and that's 50% of the world's children. WHO talks about these different typologies of violence. There's collective violence, which includes colonization, discrimination, and so forth. Then there's the interpersonal violence that we often talk about. So family violence, child-related violence and maltreatment, intimate partner violence and elder abuse. And then there's community level violence. And then there's even self-directed violence, suicide, and it's all interrelated. So if we're thinking about, in a place like this, colonization and the post-colonial era, even the fact that so much of global health has to do with aid, has to do with transfers, has to do with banks, are we really addressing the core issue about equity and about letting different countries have the means to be able to decide, is our market economy globally allowing the development of greater equity or not? And our nation states really group together to do something about global equity. My husband, who's here, is a philosopher, and we often have different discussions. But what I was saying previously, to improve health starts with governance, and to create systems and structural changes to allow these things to happen. It is not beyond our reach, but we need to create this also at a global level where it does not currently exist. It is really more of a free-for-all, and there is no real governance or structures or systems that will allow this to flourish. And I think it's hard to then make it work at national and subnational levels when there's all these inequalities that exist between countries.
Okay. Lincoln, do you want to weigh in quickly any further in terms of this Sinocentric view of?
Yeah, I want to say that China doesn't have the colonial or the immigrant history of North America and Europe, and therefore the people there, and especially the young people, do not have the experience and the skills they need, the mind and the heart that goes with the muscles for this China leadership. So you've got a muscular giant, but without the heart and mind. And that's why the Atlantic Fellows Program is so important, because our foundation, which is a Rockefeller-endowed 103-year-old foundation, has been funding regular professional degree programs. But we think that's insufficient. We think we need to break these young people out into the world to give them exposure and experience, because ultimately they are going to be the leaders. And we need to help China find its own mind and heart as a member of the global community. That's a long process, but that's the only road we have.
Wonderful. Tim, 30 seconds.
I just want to make one point on the sinocentrism, because unusually the bank was invited to make a loan to China, which you'd say, why would China need a loan from the bank? But it was based on a study that we did on the state of their healthcare system. And this study was commissioned not by the Minister of Health, but by the Minister of Finance. Because the Minister of Finance said, if the model of care that we're promoting moving forward over the next 20, 30 years is one where everybody gets care for in a facility, we're going to lose competitiveness. So he said, what does a different model of care look like whereby people are treated in the community with good primary prevention or effective secondary prevention, because I want that model of care. So we did a study which said if you take that primary care model versus your in-hospital model of provision, it's likely that your rate of growth of healthcare expenditure will be 2/3 relative to what it would be without it. And so that changed, that over time translated into 3 percentage points of GDP per annum on healthcare expenditure. So that was a very interesting value proposition for him. So the point about the sinocentrism is that China is not immune to the challenges of inequities in health, or making sure that you get good quality care for everyone. And the importance of those models of care are absolutely fundamental in sustaining security, stability, because without them, and Lincoln knows this, the Chinese people who were trying to access care in those institutions were anything but happy. And there was an
Tim, I know you're not responsible for this. This is just a second, okay? Because the Chinese asked for a greater share in the World Bank. The European and North American powers said, no, you cannot have the increased equity. And so they created their own damn bank, which is now bigger than the World Bank, okay? Which is going to be bigger than the World Bank. So that, by the way, is a tragedy of history, it seems to me, because we had one global system, but we rejected the Chinese entry into that system on a regular term, you know? And so they said, well, we'll have to create our own bank, multilateral bank.
So
I don't want to get it. That's a long set of discussion.
I'd say
but Tim was responsible for that.
Association is not attribution.
So I think we clearly have, unfortunately we don't have time for any more questions, but I think, you know, we clearly have lots of interesting issues, and the discussion will continue over lunch. So I'm going to start by thanking the panelists. So Andermann from McGill University, Tim Evans from the World Bank, Tracey Naledi from the Western Cape Government in South Africa, and Lincoln Chen from the Chinese Medical Board. And thank you all for being an attentive audience.
Good, terrific. Yeah, thank you.